So during this talk, I will focus on mainly epilepsy, but if you have any questions in general, it's okay, we can still talk about, so it doesn't have to be just epilepsy. So please make a note and then we can go through them at the end. So during this talk, I'll give you a little bit of background on TSC in general, then we can talk about epilepsy in particular, talk about prevalence of epilepsy, causes and infantile spasms. I gave similar webinar last year and I talked about epilepsy. So some of the information may be repetitive for some of you, but I know there are some people in the audience tonight who have not been to previous webinars, so it may be relevant to some other people. Then we can talk about some treatment options, current available treatment therapies, and future treatment options, and some studies in the pipeline. So this diagram shows you what happens in cells in individuals with TSC. You know, TSC is a genetic condition. It happens because you have a change or variant, we call it, in either TSC1 gene or TSC2. And these genes normally work like a switch, electric switch, as you can see here. So when they work fine, so they can turn this current off or on if it's necessary. But when they don't work, this switch is always on. And when the switch is on, you have constant current going through this cable, through this switch, and there is no blockage. There is nothing to control this current. And because you have this excessive current going through this pathway, then you get a lot of problems here because your light bulb becomes red and sore and grow rapidly because there is nothing to control it, because these two genes have lost control. So really, that's a kind of a simplistic way of explaining what happens at the cellular level in individuals with TSC. But if you want to see the actual cellular pathway, so you have the genes there, TSC1 or TSC2, and they normally suppress this pathway. So this is your switch, they suppress it. And if they suppress it, then there is no issues here. But when they can't suppress this pathway, you get a lot of problems here. And that's why you get a lot of lumps and bumps, because these cells divide constantly. There is nothing to stop them. But obviously the pathway is much more complex than this. As you can see, the genes are here, but they are linked with lots of other proteins and pathways in the cells. And that's why you get a lot of problems with TSC. So what do we know about the prevalence of TSC? Well, it's not that rare. 1 in 5, 1 in 5,000, 1 in 6,000 people in the UK have TSC. And if we compare with some other conditions like multiple sclerosis, 1 in 2,000, 1 in 3,000, cystic fibrosis, 1 in 2 or 3,000. So it's not uncommon. So there are a lot of people with TSC, but obviously it's a very, it's a wide spectrum. Some people are affected by it very mildly, some very severe. But epilepsy, again, is quite common. A lot of people with TSC have epilepsy. Not all, there are still a lot of people with TS have never had epilepsy and they will never have epilepsy. And again, the epilepsy varies. In some individuals can be severe, in some people can be quite mild. But do we know why people with TSC get epilepsy? And the honest answer, no. But we think it's probably because the tubers, the lumps people get with TSC. So this is an MRI scan, as you can see here, picture of MRI scan, yeah, of the brain. And if you look at this side of the brain, you can see a lot of white patches. These are tubers, growth, or you can call them, or hamartomas. But if you look at this side, you don't see many white patches. So this is not normal, because you see there, white patch, white, white, white. So these are all tubers. So these tubers cause epilepsy really generally. If you have someone with TSC but no white patches, I think almost certainly they don't get epilepsy. It would be very unusual to see someone with epilepsy with no tubers in the brain. So I think it's fair to say that these tubers play a significant role in generating seizure activities. But it's not just the tubers, and maybe other things are also contributing to seizure formation, because if you take these white patches out, you may still have seizures. So maybe the neighboring areas around the tubers are also contributing to seizures, because they get a bit irritated and they cause seizure activity. And this slide shows you different types of seizures, and you may have heard of tonic-clonic seizures, clonic seizures, stiffening, jerking, drops, floppy drops, and so on. So you can see people with TSC can have all these different types. One thing is not their typical absence seizures, like vacant. You just go vacant for a couple of seconds and then back. You don't even notice it. And that doesn't really happen in people with TSC. It's very rare. But all the other types can happen. And the seizures, you generally have two types of seizures. You have focal or generalized. Focal means the seizure activity comes from one part of the brain, its focus, whereas generalized comes from everywhere, both sides of the brain. But in TSC, generally is focal, well, most of the time, because of the tubers. You know, the tubers, one tuber becomes overactivated and generates a lot of seizure activity, and that causes epilepsy. Whereas generalized is more, it's different. You get this activity everywhere in the brain at the same time. But you may say, well, no, some people have bilateral seizures in both sides, both arms and both legs. This is obviously generalized, but what happens, so the seizure starts as focal in one place, and then it spreads to the other side of the brain, and then the seizures becomes generalized. Then you'll have both limb or both leg involvement. And most people start having seizures during infancy or below the age of 3. Infantile spasm is a significant issue in this population, but not everybody with TSC will have infantile spasms. Some people do. And we know if you have infantile spasms, then that can affect neurodevelopmental and cognitive outcomes, but not always. But it's important that infantile spasms are treated very promptly to reduce the effect of infantile spasm on neurocognition and development. And what we know that the lead time is important. So lead time is the time between spasm and starting treatment. If this time is short, then you are likely to do well in the future neurocognitively. But if this time is long, then that can affect your cognition in the future. So if you have infantile spasm, then we should really be prompt and treat it aggressively. And there is enough evidence to suggest that when you study people, you know, at the age of 3 and 4, if they had longer lead time, you know their neurodevelopmental outcome may be less good compared with those people who've had shorter lead time. And when we are talking about lead time, I'm talking about weeks, not months. So if your treatment starts within a week or 2, then you are likely to do better compared with someone if their treatment starts within months, let's say. So how do we treat infantile spasms? This may be relevant to some of you. The first line treatment is vigabatrin. So this is well-known drug, anti-seizure drug, and it works generally well for infantile spasms. There are some other drugs can be used for other types of seizures, and some of you may be very familiar with these drugs, the pyramide, lamotrigine, carbamazepine, and so on. This carbamazepine works better really in this population because the seizures are focal, and this drug is very good for focal seizures. Lamotrigine also works very well for focal seizures, and it's good and it's safe in pregnancy, whereas carbamazepine is less safe. Levetiracetam is a bit broad spectrum. It works for all types of seizures. And why do we think vigabatrin is good? Just for you to know, this is based on a very small study conducted 30 years ago. And it was there are only 11 patients in each arm. So 11 patients had vigabatrin, the other 11 patients had steroids. And those who were on vigabatrin, they all became seizure-free after 1 month, whereas not all the patients on steroids became seizure-free after 1 month. So this study told us that vigabatrin was effective. However, we have not done any more studies since then to confirm these findings. So we don't really know if vigabatrin, if this drug is the best drug, and if this drug is the most effective drug in this population. So we definitely need bigger trial to confirm these findings. Because at the moment, if someone has infantile spasms without TSC, they will be given steroids because steroids is much more effective for spasms than vigabatrin. Whereas in TSC, we use vigabatrin just because of this small French study done in 1997. You never know, maybe steroids is also effective in this population. So for that reason, I think we need a bigger study. Just talking about other medical treatments in this condition, you probably know this and you have seen this slide previously. This is Easter Island. It's very famous island in the TSC world because a drug, rapamycin, was discovered in the soil of this island, and this drug was found to be effective in this population. And there have been a lot of studies, both in animals and in humans, and these drugs, rapamycin and Everolimus, have been trialed and they have been shown to be effective. So initially started with animal studies. As you can see, these two little animals had TSC and they were given rapamycin, and it was shown that rapamycin was effective for their seizure control. And after that, there was a big international trial using Everolimus in individuals with TSC and looking at the effect of this drug on epilepsy. I may have shown you these slides previously. As you can see here, you have 3 groups of patients. So you've got first group here, they were taking placebo, sugar pill. It's nothing, it doesn't affect you. It's not medication. And you've got another group of patients here who are taking Everolimus, but smaller dose. And then you have higher dose of Everolimus in this group. As you can see, so this is your response rate. Looking at the seizure epilepsy response rate, you can see if you take high dose of Everolimus, your response rate is around 40%, much better if you are compared with placebo. And this is a proper study because you are comparing this drug blindly with placebo, with sugar pill, and you know the effect of this drug is very obvious. And if you take a smaller dose, you can see the effect is still quite marked compared with placebo. So there is no doubt, it's very clear from this study that this drug was effective for individuals, both children and adults with TSC. And then this another graph shows you the effect of this drug on seizure reduction. So that's median percentage change from baseline, from starting the study until the end. As you can see, the placebo group the reduction is not significant compared with this red group, the high dose group. So you can see from there comes down to this quite significant reduction. Again, if we look at this graph, we are looking at seizure-free days. Again, if you take high dose, you are likely to have more seizure-free days. So this study tells us that this drug is effective. And this table looks at, shows side effects of the study. And some of you may be already taking this drug and are familiar with the side effects. As you can see, there are a lot of side effects, but I think most of them, it's fair to say that these side effects are manageable and they can be transient. I think it's rare to stop everolimus purely because of side effects. I think most people tolerate it well, but you have to monitor them and make sure you do all the right tests and blood tests and make sure it doesn't cause any side effects. Then after this study, this drug became available in the UK. And since then, since 2018, it has become available, and we have been able to prescribe this drug since then. But what about treatment before infantile spasms? Do we need to give vigabatrin to people before they have seizures? And this question, it may be relevant to some of you, and I think there is a family in the audience. I think they have a child with TSC, but the child hasn't developed seizures. It's a really good question, but it's very hard to know what's best. And for that reason, I thought I'll just talk you through this and show you some studies to see whether this is what we can make out of this. So this slide shows you the EEG evolution of TSC. So what happens if you have TSC? When you are born, you have TSC, and EEG is brain recording. It's like ECG, you do the heart recording. This is for brain. So most children have normal EEG. So the brain recording is normal. Then you'll have spikes, then you'll have multiple spikes. Then you may have subtle focal seizures. Then you'll have significant generalized abnormal activities on the EEG. And then you'll have big clinical seizures. At the moment, the way we practice, we don't give treatment to anyone prophylactically, i.e. before they have seizures, for multiple reasons, and I'll come to that. But some people have been suggesting that maybe we should be starting treatment at this line here. As soon as you have abnormal EEG, then you should be starting treatment. And by doing that, you will be preventing seizures, okay? But there are issues with that, and I'll come to that. So this study looked at specifically at this question and see whether early treatment is helpful. So you have a child and the child has TSC, you've done an EEG, the EEG abnormal, and then you give them treatment and see what happens to them. So it was a small study, so 14 infants in the preventative group, i.e. they gave them vigabatrin before starting seizures. The other group, 31 infants, they gave them vigabatrin only after onset of clinical seizures. They had seizures and then they treated them. So that the standard practice in the UK is here, this one. We don't treat it until we see clinical seizures. And they were having a lot of EEGs and they used this dose of vigabatrin. Then that's the outcome. So you've got two groups, preventative and standard, okay? So standard practice, no treatment until seizures, preventative treatment before seizures. If you look at the number of patients with epilepsy, you can see the preventative group did better, 6 compared with 22. So that tells us that preventative treatment is good. If you give vigabatrin early, then you are less likely to develop epilepsy in the future. And if you look at the patients with infantile spasms, again, 2 versus 11, again, that looks good. If you look at intellectual disability, 2 in the preventative group versus 15 in the standard group. So all in all, this table tells us that early treatment is good. But is that enough? Can we rely on this study to give vigabatrin? Because this drug can cause problems. Some of you may be familiar with this. it can cause visual field defect, can affect your vision. And the answer is no, because it's a small study, it's not a proper randomized double-blind controlled trial. It's an open label. So you decide to choose placebo and you decide to choose the treatment option. So it's not randomly allocated and it's not blinded. And that's why you have to be really careful when you analyze data from open label studies. And there was another study, well, extension of that study. So they followed these kids to see what happens to them at the age of 5, because you get better, reliable neurodevelopmental outcome if you assess neurocognition on children when they are a bit older, because you can talk to them, you can ask them to do things. So in the preventative group, they still had 14 patients, whereas some patients lost follow-up from the standard group. And you always worry when people don't continue the study, because you may think, oh, because they were not responding very well, or maybe something went wrong, that's why they left the study. So not all the patients complete the study. So again, this table shows you, as you can see, preventative group, standard group. If we look at the IQ, you can see the preventative group IQ is better than the standard group. If you look at patients with epilepsy, 3 versus 15. So most of these numbers you can see here, these are all better compared with this side. So again, the follow-up study shows us that the preventative treatment, it was better than the standard treatment. Again, this was an open label study. We can't rely on it because it wasn't done in a randomized control trial. So the only really solution we have to answer this question confidently, that we need a bigger randomized control trial to see whether early treatment is effective. And if it is, then we will be giving vigabatrin before seizure activities. So talking briefly about some other treatment options in TSC and epilepsy, vagal nerve stimulation is very important. And I think all patients with TSC and epilepsy should be assessed for epilepsy surgery. And vagal nerve stimulation is part of the epilepsy surgery program. And you may be or you may not be familiar, this is a small device, it's under the skin here in the chest, and this sends signals into the vagus nerve, which is in the neck, and for some unknown reason, stimulating the vagus nerve controls or can control seizure activity. And generally is well tolerated. And if you're not familiar with this, it doesn't really cause significant side effects. The only problem I have with VNS in TSC, if you have a VNS, you will not be able to have abdominal MRI scan for kidney angiomyolipoma monitoring. You see, sometimes we say people should have an abdominal MRI scan to make sure that their angiomyolipoma is not growing hugely. And if you have this VNS, you cannot do abdominal MRIs. We don't have we don't have any MRI scan compatible with VNS for abdomen. We can do brain MRI scan. We have a special coil and receiver we use, but as soon as you go down to the abdominal area, you can't do it. So that's the only issue, but I think people should still be assessed for that. There are other types of surgical interventions. This slide just shows you what happens if you go through the epilepsy surgery program. Maybe some of you are already been through this and familiar. So you get special scans and see which part of the brain is active. And you have special EEG, as you can see, and this records electrical activities in the brain. You have different types of epilepsy surgery interventions. In this slide, this is an MRI scan. As you can see, this patient has a big tumor we talked about earlier. It's a big lesion in the brain, right side of the brain. This is before surgery, and this is after surgery. As you can see, the tumor has been removed, and this patient responded very well, and he became seizure-free after this. There is another type of surgery. It's hemispherotomy, so you disconnect one half of the brain. If you know you have a lot of seizure activity from one side, you can disconnect this side from the brain So this side will not be able to generate seizure activity because it has been disconnected. So that can be done as well. Obviously, that's for more extreme cases. There is another surgical approach you can do called corpus callosotomy. So this is an MRI scan. It's taken from one side of the head, as you can see, nose, mouth, tongue, and that's the brain. This C-shaped band called corpus callosum, it's like a fibrous tissue, connects the two parts of the brain, right and left, sits in the middle like a C shape. And a lot of people with drop attacks respond very well to corpus callosotomy. So you remove the corpus callosum, and that can improve drop attacks. So if someone has drop attacks, should be considered with corpus callosotomy through the epilepsy surgery program. Going back to the mTOR pathway I showed you earlier, we know this is the mTOR pathway, we know these are the genes, and we know rapamycin and everolimus have been effective. Then we used another drug called metformin. I don't know who's online, but maybe some of you were already part of this study we conducted a couple of years ago. And you may know metformin is used for diabetes and polycystic ovary disease. And when you read the history, it's very interesting, metformin, because when metformin came out, people used to use it to treat influenza and malaria because they thought it had some antimicrobial effects. Then people started using it to treat diabetes, high blood sugar. Then it was banned because they thought it was it's a bad drug. And there was a better drug came out, insulin, at the time. And that's why metformin became very unpopular. It was banned in some countries. But then in the last 30 years, metformin came out again because people realized, oh, after all, it's not that bad. And now it's become one of the essential drugs on the WHO list. But when you read about metformin, it works almost for everything, literally everything. Maybe some of you are already taking metformin and you have diabetes, and I think you'll be pleased when you see this slide because it does help you a lot for lots of other things. It helps with the aging process because it has some anti-inflammatory effect, affects your DNA repair process. It can affect the cardiovascular system, affects your cholesterol level, regulates your weight, can affect the neuropsychiatric disorders, depression, cognitive ability. It can help kids with Duchenne muscular dystrophy through mitochondrial energy enhancing effect. And we know it has a significant anti-cancer effect. So the COVID business, I didn't know about this COVID. I gave a talk to some colleagues in Southampton last week. And when I was preparing this slide, and I should maybe Google, see whether COVID is good for, metformin is good for COVID. Believe it or not, I come across 22 studies. People have already looked at the effect of metformin and COVID. And these studies have all shown that metformin is good for COVID as well. It has some anti-inflammatory effect, and it's good for their immune system. So there you go. Metformin cures COVID as well. But when you look at the cellular level, we know metformin works on the same mTOR pathway, the pathway which is overactivated in people with TSC. And we know it has significant anti-cancer property, both in animal studies, in cell studies, and in human studies. So if you have diabetes, and if you are taking metformin, you are less likely to get cancer compared with someone else who doesn't take metformin. And the tumor completion response rate is better if you are on metformin, and distant metastasis rate is also better if you are taking metformin. So I think there's a lot of evidence to suggest that this drug is good. And if you are really interested in the cellular pathway of metformin, as you can see, it works on the TSC genes through different pathways. So we conducted a study and looking at metformin in TSC, and the primary focus was looking at kidney angiomyolipomas and brain giant cell astrocytomas to see whether this drug shrinks these hamartomas. So these slides, so these are patients with subependymal giant cell astrocytomas, which are benign tumors in the brain. So this is your baseline. So anything below this is good. Anything above this line is not less good. So this is the treatment group, and this is the placebo group. So half of the patients received treatment, metformin, the other half received placebo. As you can see, you have seen more of these in the treatment, the downwards in the treatment group compared with the placebo. Yeah. So this slide tells us that this drug was effective in shrinking the subependymal giant cell astrocytomas in patients who were taken it, compared with patients on placebo. So that was good. When we look at the effect of this drug on kidney angiomyolipomas, it was less impressive compared with subependymal giant cell astrocytoma. As you can see here, you can still see more patients below this line, the treatment group, compared with this. And those who are above the line, here, you can see it's more pronounced. The growth is more pronounced in the placebo group compared with the treatment group. Basically, this slide again shows you that those patients who were on metformin did slightly better in terms of kidney angiomyolipoma. When you look at the epilepsy data, again, the treatment effect was obvious. So the median reduction was about 40% compared with baseline. So again, this slide tells us that this drug showed some effect on epilepsy and seizure activity. Then moving on and focusing on Epidiolex and Cannabinoid, you probably know about this drug. It has been used for a while, for a long time, marijuana, for epilepsy and for other conditions. You may know this is derived from sativa plants, and the active ingredient is the THC, tetrahydrocannabinol. And this is the psychoactive ingredient within Epidiolex. But we don't exactly know the effect of THC on IQ, mental health, and brain development, because the studies have always used very small amount of THC, but we don't know if you take high dose of THC, what happens to your brain growth, what happens to your IQ and mental health. So CBD is not just being used for epilepsy, it has been used for various neurological and non-neurological, Crohn's, Parkinson's, stiffness, abnormal movement, pain, anxiety, epilepsy, and so on. So the indication is expanding. But we are interested in epilepsy and TSC, obviously, and the mechanism of its action is very complicated, and we don't really know exactly how it works, but we think it works on calcium ions in the cells in the brain and central nervous system. So at the moment, this drug is available for 2 epilepsy conditions, Dravet syndrome and Lennox-Gastaut syndrome. And there was a big international study looking at the effect of this drug on patients with TSC and epilepsy. And they used 2 doses, 25 milligram per kilogram per day and 50 milligram per kilogram per day versus placebo sugar pill. And the study showed that this drug is effective for epilepsy in TSC. So if I just show you this slide, you've got 3 groups: placebo, low dose or medium dose, and high dose. And we are looking at primary endpoint seizures, or we are looking at total seizures. If we look at the total seizures, so these patients were on Epidiolex, these two groups, compared with placebo. As you can see, the difference in their seizure frequency, reduction in seizure frequency was significant. Yeah. So if you take placebo, that's your seizure reduction frequency compared with Epidiolex. Again, this slide tells you that this drug was effective for epilepsy. And there were further analyses looking at how many people had more than 50% reduction in their seizure frequency and how many people had more than 75% reduction. So you can see some people who were in this study had more than 75% in seizure frequency. And that's quite a big deal, that's quite significant. 75, it is important. But if you take this drug with clobazam, then it's likely to be more effective. And we know Epidiolex and clobazam work very well together. They help each other, but they cause problems together as well. Yeah. And this study shows us here, you can see these patients were taking clobazam. So if you take clobazam and Epidiolex, that's the difference between you and placebo. But if we take Epidiolex without clobazam, that's the difference between our seizure frequency and those people who are on placebo. You can see the difference here is much smaller than the difference here. So again, this slide tells us if you take clobazam and Epidiolex, then it can be more effective for your seizures. This shows you the side effects of Epidiolex. Again, you may be familiar with this. So the only side effects we worry about is abnormal liver function. And that happens quite often. And you need to keep an eye on the liver function. So if you are taking Epidiolex, you need to make sure you have regular blood tests, because if your ALT, if your liver function becomes deranged for a long time, that can cause significant issues in the future. So if you are on this, ALT check is very important. It can cause other side effects, but generally they are not significant. Gastrointestinal side effects can happen, but again, they can be transient and they are not problematic. So the study concluded that Epidiolex is effective and it's safe in children and adults with TSC for epilepsy. So currently in the UK or in England, NICE guideline has approved Epidiolex for LGS, Lennox-Gastaut, and Dravet syndrome, but not for TSC. So what's happening, and Louise is online, maybe she will update us on this later on during the Q&A session. So at the moment, we have got MHRA approval in the UK, which is great news, because if you want to use any drug or new drug in the UK, you need to get MHRA approval. And you probably heard a lot about MHRA during pandemic when we were using new vaccines. So any new drug requires MHRA. So we have MHRA approval. So that's a very important step. In Scotland, so they have obtained approval. So the Scottish Medicines Consortium has given approval, go ahead to use this drug. Same as Wales, but in England, we have not got NICE approval yet. And without NICE approval, we will not be able to prescribe this drug, and there will be no funding until there is NICE. So there is a meeting in September with NICE. I'm going to attend this meeting, and I'm sure Louise and other colleagues from the TSA will be attending this meeting. And I'm personally positive that we will have enough evidence to support this application and to make sure that we'll get NICE approval. And hopefully this approval will come about in November time. Then after that, we should be able to start using this drug in England for patients with TSC and epilepsy. Obviously, your epilepsy has to be severe enough to require this treatment. And I'm sure we will have some certain criteria for prescribing, but I suspect a lot of people with epilepsy will be eligible to receive this drug. And TSA has done a lot of work to make sure that we get this nice approval as soon as possible. As you can see, the date was initially April 2023, but that has been brought forward to December 2022. So we are very keen to get this sorted as soon as possible. So that's Epidiolex and epilepsy. So there is another study in the pipeline. In fact, I'm meeting with GW Pharma tomorrow afternoon to discuss this study. So that's quite exciting. So the plan is to use Epidiolex and check its efficacy on other issues in TSC, because it's not just about epilepsy. There are a lot of other issues people suffer from in with TSC: cognition, behavior, mood, quality of life, sleep, and so on. So the idea is to trial this drug and to check its efficacy on these domains. Look at behavior, look at memory, executive function, mood, quality of life, sleep, and so on. And as you can see here, the inclusion criteria, it's quite wide. So children aged 2 to 65, so a lot of people will be eligible to receive this drug, which is quite interesting. But your IQ has to be at least 60 and above to be able to, so that we can do these assessments and some other inclusion criteria. So it looks and sounds very promising, and hopefully this study will start soon. I think the plan is to start this study as soon as possible. Then just to talk to you about this product, Ganaxolone, briefly. We are progressing well with this. This is a neurosteroid, and it works in the brain and works on some receptors in the brain. We call it GABA, and we know this, it's a good anti-seizure drug. The reason we know it's a good anti-seizure drug, we've just completed this study. We used this drug in a different condition called CDKL5 deficiency disorder, which causes very severe epilepsy and learning disabilities. And this was a randomized, double-blind international study. So we looked at the effect of this drug on epilepsy. As you can see, the study showed that this drug was effective. Those people who were taking Ganaxolone had nearly 30% seizure reduction compared with placebo, which was 4% again. So you can see the difference is quite significant. And when you look at the safety profile, side effects, the side effects are not significant. People who were taking Ganaxolone had somnolence. So it can make you drowsy compared with placebo, but again, it's dose dependent and it's not permanent side effects. You can modify the dose, and quite often most people get used to it. So it's not a major issue. So this study showed us that this drug was effective for this population, and it's also safe. But we don't know whether this drug is going to be effective in patients with TSC. So the plan is to do again a phase 3 double-blind randomized placebo-controlled trial. We will have 2 groups, Ganaxolone and placebo. So this is the proposal. So we are planning to recruit 162 patients. Then we will randomize the group. So the machine, the computer, will decide who goes on placebo and who goes on Ganaxolone initially. Yeah, you have 2 groups for 12 weeks, nice and short duration. And then after the 12 weeks, everybody will be given Ganaxolone, because I think it's just unfair for people to take part in studies and just take sugar pills and nothing at the end. So you will get Ganaxolone at the end in this open label extension. And then we will assess the efficacy of this drug. So I'm positive that this drug is likely to be effective in patients with TSC as well, because when you look at the cellular pathway, I think there is no reason not to think that is not. I think it's very likely to be effective. So it looks very promising. And the way we've designed it, the inclusion criteria is quite broad. A lot of people will be eligible. You can see the age range from 1 to 65, but obviously your seizures or epilepsy has to be really bad enough to require another new anti-seizure medication. So we've put 2 or more anti-seizure medications. So you should have tried at least 2 or more anti-seizure medications in the past. And when you are in the study, you have to be on a stable medication plan, and you should have had at least 8 countable seizures in the 2 months prior to screening, so that you have enough seizures so that we can count the seizures. Because if you have 1 seizure once a day, then you won't be able to know whether this drug is effective or not, because we can't count. It's not frequent enough. So you need to have enough seizures. So we've just in the process of submitting the ethical approval in the UK, and that shouldn't take more than 2 to 3 months. So I'm hopeful that this year we might be able to start recruitment, and we will make sure that we will have at least 2-3 recruiting centers in the UK, so that people can join these sites rather than traveling for hours and hours to attend 1 or 2 centers. So I think we will make sure at least 3 to 4 centers in the country. Very briefly to tell you, there is another drug in the pipeline. We are hoping to set up another study to use this drug called fenfluramine in TSC and epilepsy. Fenfluramine was previously used for weight loss, but we are beginning to know that it has other actions. It works on serotonin and some other hormones in the brain, and it's likely to be a good anti-seizure medication, especially in TSC. And I've listed all the reasons why I think this drug is likely to be effective in TSC. I'm trying to find some funding to set up a study to do this, and we've Zogenix is a pharmaceutical company. I think they've been very keen to support us with this study. We are working with them. We just need to find out how to run the study and get all the appropriate approval for the study, but hopefully this will happen in the future. This drug was used in 2 other epilepsy conditions, Dravet syndrome and Lennox-Gastaut. Again, the drug was effective and it didn't cause a lot of side effects. And these graphs just shows you the effect of this drug on seizure activities when you take fenfluramine. I've got only a couple of slides, then I will stop. There's another drug in the pipeline called antisense oligonucleotides. It's like gene therapy, but it's not quite like gene therapy, but it's a bit like gene therapy. It works on regulating genes, mRNA in the DNA. The product hasn't been finalized yet. There is no product, but I think I had a meeting some weeks ago with some scientists. I think they are working on this and trying to create this product. I think sounds very interesting. And that regulates the mRNA and regulates the mTOR activity in the cells. And that could really treat seizures in a different way through the DNA rather than through anti-seizure medication. So it's very novel and it's very different from all the other drugs we have been using over the years. This technique has been used in some other neurological conditions like SMA and so on, and it has been quite successful. The only issue I have with this approach, this drug has to be delivered through a lumbar puncture, like epidural. So you have to stick a needle into the back, which can be a bit painful and invasive and has to be given regularly. But given that it's only new, I suspect the delivery technique will change, and I'm sure they will make it easier. So we'll have to just see what happens. But this is quite exciting, and a lot of people are working on these novel approaches in this field. There is another study, Dr. Chris Kingswood and I are working with a company. They are trying to create an agent. I think they have already created the agent, but they are working on it and to make sure that it's effective in this population. Again, it is slightly different from all the other drugs have been used previously. So the idea is to take blood sample from 10 patients in the UK, some on everolimus, some without everolimus, and look at these chemicals and then see whether this new agent works. So hopefully we'll start the study and we'll ask people to take part in the study. It will involve only one blood test, so it's quite low maintenance study, but I think it'll be really helpful. It will give us a lot of information, and I think this new agent, I haven't been given the name yet, so they are not in a position to disclose the name, but I think it sounds very interesting, and it's likely to cause less side effects compared with all the other drugs we have been using for TSC. This is my last slide. You've probably seen this slide. Just to remind you, we have a study in Bristol. Well, it's a national study, but it's based in Bristol. We are trialing this new technique called acceptance and commitment therapy in TSC. It's like a talking counseling therapy, and I think it's really good. Well, I would say that because it's our study, I would say, but I think it's helpful because I know a lot of people with TSC cannot access neuropsychology. And if you're part of this study, you'll be able to access neuropsychology for free. There is no waiting for it. And you don't have to travel to any clinic. So it's all done completely virtually. All you need to do, just email us if you are interested. You can either email me directly, or you can email Alex, who's our neuropsychologist, who's the main researcher for this study. At the moment, the age criteria is 11 to 24, but we may need to consider this age inclusion in the near future if we are not, if we think this is a limiting factor for recruitment. But please let us know if you are interested, and you will get 12 sessions of therapy, and it's all done virtually. Thank you very much for listening, and I would be happy to take your questions. I'll stop sharing.
Thank you very much, Sam. That was really interesting, and I think a lot of people were taking down notes frantically. But we have a couple of questions in the chat, if we're okay to start with those. So Molly has asked, is it possible to tell from a child with TSC's brain scan the areas of their development that will be affected by the tubers, and if this will affect their attainment within certain areas of development?
I think it's a really good question. I think it's really hard to be able to say with certainty and prognosticate. And some colleagues in Europe have looked at the number of tubers and the location of tubers in the brain, but we don't really have good evidence to suggest if you have X number of tubers or tubers in this location in the brain, and you are likely to have these problems. I think if you don't have any tubers, the white patches I showed earlier, I think you are unlikely to have autism and learning issues. I think it's very unusual. I can't say it's not going to happen ever, but I think if your scan doesn't show any tubers, then I think you can be certain to some extent that the chance of having ASD or other cognitive issues, I think, is very slim.
Thank you. So we have another question from Tracy. So it says, hi, my 27-year-old daughter has started Everolimus a week and a half ago. She also has PCOS and type 2 diabetes. After hearing about Metformin, can you take this alongside Everolimus and other anti-epileptic meds?
Yeah, I'm glad you asked this question. I think that's really, I should have mentioned that during the talk. So we know Everolimus is a very strong mTOR inhibitor, but Metformin is a weak mTOR inhibitor. Okay, we know Everolimus is much more effective than Metformin. And what's good about Metformin, if you don't want to use a high dose of everolimus because of side effects, what you can do, you can use a small dose of everolimus to avoid side effects with metformin. By doing that, you'll be able to control the mTOR pathway, but without having significant side effects, because the metformin, we know it's safe, doesn't cause significant side effects. And if you use a small dose of everolimus, then you are okay in terms of side effects. So I think using both together, I think it's a really good idea. And it shouldn't cause more side effects, and they don't interact badly together.
Great, thank you. So we've got quite a few more. We'll try and get through as many as we can. So the next one is Eva. Is it true that seizures are the most unpredictable at the first? I'm not sure if that's cut off early. It just says at the first. Is it true that seizures? I'm not sure. I don't know if you want to unmute Eva to explain what you mean by that. We'll move on to the next question. We can come back to that one. So Kathy says, as a child, oh, go on then.
I was going to say, Anna, Eva's added on, is it true that the seizures are most unpredictable for the first 10 years of a child's life?
Perfect.
Again, very important question, interesting. Generally, most seizures start during the first year of life. And there are people who present with seizures when they are 6, 7, 8, even 10 or 12. But I think the longer you go, the risk of epilepsy gets much, much smaller. So I think if you've not had any seizures in the first 10 years of life, then I think you can be comfortable. I think the risk is very small.
So the next
But
one
we
is,
can't say you will never have seizures. I think you will always be at risk of seizures, because if you have tubers in the brain, because the tubers are always there. But if you leave it long, then your brain cells would have adapted to the tubers and would have found other pathways and networks in the brain. So I think, yes, the answer to your question, the risk is small, and it gets smaller and smaller.
thank you. So Kathy has asked, as a general, if you can control seizures, will a child or person improve or develop cognitively?
Yeah, so when I showed the slide about infantile spasms, yes, so there is a strong link between controlling spasms early and the neurodevelopmental outcome. If you remember, I showed the lead time. So if the lead time is short, then the neurocognitive outcome is likely to be better. So if you see someone with infantile spasms, prompt treatment is very important. Treatment should be initiated as soon as possible. And if you control that, then the outcome is likely to be better than someone who've not been treated for months with infantile spasms.
So the next one is Sandy. She's put, my son is 34 years old, diagnosed at 0 months old. He is currently prescribed Everolimus for kidney AMLs, but they do not have any effect on his seizures. Would metformin be suitable, as his seizures are really disruptive?
Yeah, so metformin is it's off license, off label, so it can be prescribed really by any GP. So, and I can't think of any strong contraindication for metformin. I think most people should be able to take metformin. It shouldn't cause a lot of side effects. So I would suggest that you have this discussion with your GP. And most GPs are very familiar with metformin because they have a lot of patients with diabetes. So it's commonly prescribed drug. It's very old drug. It's been out there for a long time, and it's not costly at all. It costs about 50p per month or something. So it's not a huge burden. So your GP should be able to support you with that.
Thank you. So we've got another one from Nick. Our son started on vigabatrin a week after starting with infantile spasms. He became seizure-free after the first dose, but how long would you recommend staying on the drug for?
Well, I'm glad you asked this question. Maybe I should have mentioned that during my talk. You are all asking really very important, very interesting, very controversial questions, and most of them I don't have any answer. So honestly, we don't know the duration of vigabatrin. So generally, I use vigabatrin for 2 years in TSC. But if you don't have TSC, we use vagobatrin for 3 months. And the reason I use vagobatrin for 3 years, because I don't want any relapse of spasms. Because you have the tubers, the risk of relapse is high. Therefore, I think it's safer to be generous with it and use it for 2 years. I know some colleagues in the UK use it for 6 months, 12 months. Again, we haven't done a proper study to compare 3 months versus 12 months, 3 months versus 24 months, and so on. But I'm just worry about relapse, and I like to be generous. So my recommendation is 2 years, unless there is some contraindication or something you're worried about.
Thank you, Sam. So we have another one from Gemma. We were wondering why an IQ or development test hasn't already been carried out for the use of CBD/THC, considering it has been used for 150 years.
Well, because it's very, very difficult to do these trials. It requires a lot of regulatory approval and it requires funding. It's not easy to conduct clinical trials and medicinal trials, but it's good now GW Pharma/Jazz are interested in this field. And I showed you this slide using Epidiolex CBD and using its efficacy, looking at its efficacy on other comorbidities in TSC, including behavior, cognition, IQ, and so on. So it will happen, but yes, you're right, it has taken for a very long time.
Thank you. There's another one. We were due to start Everolimus 2 years ago, but this was stalled because of COVID due to us being on the Isle of Man. Our son is now transitioning to adult services at Walton, so we would be looking at this again. We would like to know, should we start Everolimus or wait for Epidiolex? He has generalized seizures, approximately 10 to 20 a day.
Well, I would say if Everolimus is available and if your clinicians are happy to initiate it, then you've got this drug available. I would say go ahead, as long as you fit the eligibility criteria. I'm sure your local clinicians would have done that, and if you are happy with this, I can't see any reason why not. And the issue between COVID and Everolimus and immunosuppression, I don't think we have any strong evidence to suggest that Everolimus is contraindicated or it's a bad thing to use during COVID pandemic. We haven't seen many complications in regards to Everolimus and COVID. So I would say if Everolimus is available, go ahead and use it.
Thank you, Sam. And we have one from Joan. If you are older and you have a few 15-second seizures a month, should you continue seeking out more or different drugs to be completely seizure-free?
15-second.
That's what it says.
Yeah, so I think, again, that's a very important question. And we always debate about this, the effect of short seizures. It's not always about the duration of the seizure or the frequency, because some people get, especially regulatory authorities and sometimes pharmaceutical companies, get fixated on seizure frequency. But you may have one seizure every 6 months and the impact may be quite significant. And you may have 3 seizures every day, but the impact may not be that significant. So I think it's really important whether this one little seizure is significant. Do you get sleepy 12 hours after this short seizure? And if you do, then the impact is quite significant. But if this small seizure doesn't affect you, you are still fully functioning, doesn't worry you at all, then probably it's not that significant. So really you have to look at the whole picture.
So we've got 4 more questions and then we'll have to wrap up. So I'll just go through these 4. So Alice says, my 32-year-old daughter has tried at least 6 AEDs and many combinations. She is taking 4 drugs, including clobazam at the moment, but still has around 10 to 15 fits a month. Is it worth her trying another drug, and which one? The constant disappointment gets her down. Thank you.
Yes, so I think unfortunately sometimes it's very difficult to control seizures, but I would always try something else if it's available and if it's safe. And And if you are keen for a better seizure control, then I think there's always some options. You've got I didn't mention the ketogenic diet, so that's an important option. Epilepsy surgery program is another important option, vagal nerve stimulation. As you know, Epidiolex we talked about, Everolimus we talked about. So I don't know whether these drugs have been considered in your case, whether epilepsy surgery or ketogenic diet have been considered. But if you think the seizures are frequent and they have significant impact, then I would say I think it's worth revisiting the agents again and again, maybe doing another EEG to see what's going on, where the activities are coming from, and so on.
Thank you, Sam. So Maria said Tristan, our 35-year-old, is already taking 5 AEDs and about to start an Epidiolex because they're in Wales. Is there a general opinion on the optimum or limit on the number of AEDs?
Hi, Maria, nice to hear from you. And I hope Tristan is doing well. I haven't seen you for a long time. So number of AEDs, no, there isn't. But obviously we need to make sure that there is no significant side effects. But in terms of maximum number of anti-seizure medications, there is no limit. Something we call it polypharmacy. We never like polypharmacy, and we know if you try lots of drugs, you will just confuse the system, the networking in the brain, because you'll be targeting different pathways and different cells and different receptors. So I think, and you are likely to cause a lot of side effects. So I think it's good to make sure that you don't use too many drugs together. Generally, I really don't like using more than 3 or 4 drugs at the same time in one individual. But I have a lot of patients who are on more than 4 agents. But I think it's always to make sure. And if you are on a drug and if the drug is not working, I think you should just get rid of it, because there is no point in using it. I think it's always important to review and revisit these drugs. You are using it to improve quality of life and improve epilepsy. And if they are not doing that, then I think they should just be banned.
Thank you, Sam. So Anne-Marie has asked, her daughter is 18 and she's taken lots of drugs. She's on Everolimus, but it's not helping her seizures. Next suggested is Bivaresetam. Metformin has never been mentioned. Is it worth discussing with the neurologist?
Yeah, I think it would be, you've seen the data, and I think we've presented the metformin study in a couple of neurology meetings in the UK. I think most of the pediatric neurologists hopefully would have known about this, but obviously I would be very happy to share my opinion and about metformin if they can contact me. Yes, if you are interested, I think it's not a bad idea to discuss this option with your clinician. And I don't think anyone would object that, because as I said, it's a very safe drug. There is no issues with funding. Whilst we are waiting for Epidiolex, and maybe it's worth exploring this option.
Great, thank you. So there's one last question from Hannah, and then we'll wrap up. But there's lots of thanks in the chat for you as well, Dr. Sam Amin. So this question is, as there is a 50-50 chance I can pass TSC onto my child, are there any studies on if the mother has mild TSC that the child might have mild TSC too? So you don't have to have genetic IVF.
No, unfortunately, it doesn't work like that. So if you have mild TSC, it doesn't mean that your child will be mild as well. Depends really on the type of the mutation. You know, you have 2 types, TSC1 or TSC2. Quite often TSC2 is worse than TSC1. But again, you can't really reliably rely on that. You can still have TSC1 and it could be severe. You can have TSC2 and you can be mild. I know a lot of people with TSC2 and their TSC is very mild. So you can't rely on that. But you know, most people with TSC will have, well, 50% of people with TSC don't have a lot of issues. So there is still a good chance, even if your child has TSC and they may not have a lot of issues, complications. But as you know, there is test can be done before fertilization and so on.
That's great, thank you. We'll also recommend, Hannah, if you want to get in contact with the TSA support line, I'll put the details in the chat. We'd be able to also get you a referral or put you in touch with a clinical geneticist as well, if that would be helpful. But yeah, so I think that's all the questions in the chat. But there's a lot of people.
There is a hand.
Oh, is there a hand? Yes, so it says Brown family, I think. Do you want to unmute and just ask your question before we wrap up?
Sorry, it's Joe. Thank you, Dr. Amin. It's been a wonderful information there for us all. But you mentioned when you were talking about the seizures, cortical tubers and the neighbouring areas being irritated. My daughter's 17 and she's had every seizure, listed. But you said about absent seizures being very rare, and she has a lot of absent seizures. And actually, just lately she's having them sort of 60 odd a day. If we can catch them, they're quite brief. Some of them go on a little bit longer. So just wondered, is that she has TSC too? So is that quite unusual? Is that something we should be? She's on 2 AEDs, clobazam and sodium valproate at the moment. And she's having an EEG next week, actually, because I'm very concerned, obviously she's exhausted after these. So the typically, so we have 2 types of absences. You have typical absences and you have atypical absences. So the typical absences, it starts very rapidly, and it goes very rapidly. So you don't get tired before or after. There is no warning. Literally, you just become vacant for seconds and then disappears. So that's your typical. So this type is very rare in TSC. I suspect your daughter probably has been having the atypical absences. You become a bit tired. Sometimes you have some movements with it. Sometimes you may have some jerks with it. So it's possible. She has a tremor in her hand, slight tremor in her hand. Constantly.
So I think that's probably the atypical ones.
Okay.
Has she tried other medications or has she just tried these 2?
No, over the years she started on the vigabatrin, is it? She's had the levetiracetam as well, and the one we found really that's worked for about the last 10 years has been the clobazam epilim combination. But obviously now it's breaking through. Obviously something's not covering the same. So
I think, as you say, I think it's worth doing an EEG to see what's going on and what's happening with the brain activity. And maybe ketogenic diet and there are other options available. So I think it's worth looking at the other options. It sounds like the impact is quite significant. I know they are absent seizures, they are not big motor seizures, but if the impact is significant, I think it's worth exploring other treatment options.
Lovely, thank you.
And if the EEG shows this condition, Lennox-Gastaut syndrome, then she will be eligible to receive Epidiolex now.
Right, yes.
So
we are in Wales as well, so I don't know with the Everolimus, I don't know how that works because we're in Wales. So
I think it's worth getting the EEG and see what's going on. I think that should be the first step. I think the EEG would be informative, but there are a lot of other options can be used in your daughter's scenario.
Lovely, thank you very much.
That's great. Thank you, everybody. Well, thank you so much, Sam, for tonight's session. It's been so informative, and I think it's been really helpful for everybody who's attended, and hopefully a lot of people who watch the recording afterwards as well. So thank you so much, and thank you, everybody, for all your questions.
Thank you all. Have a good evening.
Thank you. Take care. Bye-bye.
Bye.